Okay. Oh, that's right. And I will tell you that, committee, mistakenly, I announced that Representative Bryce's father had passed away. But Representative Bryce, you might be able to elaborate a little bit on that. But you still were in our prayers, so.
Thank you for your prayers. Yeah, my father is very, very ill, but he's with us and comfortable. I'm Ron Bryce. I'm in District 11, which is Montgomery County, Southeast Kansas, and this is my second term to be a legislator. So this will be my third year on the committee, and it's been much more exciting than I anticipated, and I anticipate it'll be exciting this year. So I'm happy to be here.
Very good. Thank you. Thank you guys for that. Okay. Next, we will have a presentation from one of the smaller agencies in our, if not the smallest agency in our state, Janet Sterick and KDHE. So, Madam Secretary, welcome to committee.
Thank you. Some of you saw me the other day, if you're in Social Service Committee. I took the directive to be 15 minutes literally, so I have created an alternate slide deck off of these, and if anybody wants more detail, just stop me. I have with me Deputy Secretary Ashley Goss from Public Health and Deputy Secretary for Agency Integration Medicaid Director Christine Osterlund to help me. So I'm going to start with the mission of Kansas Department of Health and Environment to protect and improve the health and environment of all Kansans. We have three divisions: Public Health, Medicaid, also known as the Division of Healthcare Finance, and Environment. But today we will focus on Medicaid and Public Health. We also then, on the slide, you can see we have an administrative office with IT and accounts payable, procurement, and whatnot. The focus areas of KDHE from my level are first and foremost personnel are our most important asset. We can't do our job without them. So we are going to recruit and retain all levels of staff to carry out the mission of the agency, and we're doing pretty well on that, and also in retention. We adhere to and assure that we are operating under legal, legislative, and federal requirements. We are very federally mandated and driven, as well as statutorily at the state. We have to manage a lot of money we dish out that comes back from partners that we have to make sure we're adhering to so we can continue to fund programs. We're very supportive of partners, our stakeholders. They're an asset to us. They help us get things done. We listen, we collaborate. We are continuing to align, fund, and leverage those resources to get us some leverage on programs. And within our own agency, Public Health and Medicaid don't always talk. We're getting much better at that with KDADs and other agencies throughout the state as well, doing more together. You will see the Division of Public Health and the mission there, and it's pretty much to promote and prevent disease and outbreaks among the people of Kansas. We do this through assessment, policy development, and assurance that things get done. There are a list, and there is detailed in the slide deck, and I'll ask if anybody wants more detail from me to read that or refer to this, but the Bureau of Public Health under Ashley's direction has the Bureau of Community Health Systems, the Bureau of Facilities and Licensing, which means we license everything but nursing homes. We do hospitals and so forth. Epidemiology and Public Informatics, which basically is disease tracking, reports, studies, and so forth. We promote health. That's through wellness programs, initiatives throughout the state. The Bureau of Disease Control and Prevention, and I'll talk about an initiative there in a minute, very important. The Bureau of Oral Health, we have a chief dental officer for the state as well. The Bureau of Family Health, and basically the Kansas Department of Health Laboratories, this new building that you are seeing erected that will go live soon, is under the Division of Public Health as well. I, again, will not read every aspect of what those bureaus do unless someone has questions. They are in your slide deck. I'm going to jump to the slide that talks about the public health accomplishments. We were recently reaccredited after our first accreditation, which was 5 years ago, by the Public Health Accreditation Board. It's a big deal to get FAB accredited. It took 3 years of continuous and meticulous work, not only within the Public Health Division, but the entire agency and partners as well. So we're very proud of that. In an effort to reduce the misuse of antibiotics leading to antibiotic resistance and ineffectiveness, the epidemiology staff analyzed data and inappropriate prescribing practices, and then we were able to give this feedback back to healthcare providers so they could improve their programs and improve the patient care delivery and lives of Arkansans through antibiotic stewardship. We have a home visiting program in the maternal and infant and early childhood visiting program, and we increased the number of visits that we did by 31% throughout the state. Child care licensing, you know, child care is a big initiative on the governor's agenda. We are one of those component agencies that administers child care licensing. We had to do a major rewrite and address 43 regulations in less than a year, and those regulations went into effect August 2nd. We mobilized staff and resources addressing, and this was in the disease control and prevention unit, this unprecedented tuberculosis outbreak in collaboration with the CDC. And that is still underway, and we are making progress in one of our counties here in Kansas. And with the lab, known as K-Health, in collaboration with the Department of Administration, who oversees the project, we completed the design, construction, and we are now in the process of moving in different components of our lab from the Forbes Field lab to the lab over here behind the Judicial Center. And we are at different stages right now of relocating. We anticipate opening no later than June in full force, but there are different things going on that cause, we have to get equipment recalibrated and tested and approved by other outside agencies. But it's going to be a great thing for the state of Kansas in general, not just Topeka. Our goals for upcoming year include ending that TB outbreak. It's been very difficult and an arduous task, but we are making progress as noted. Public Health is going to work collaboratively with Medicaid on a newly awarded what's known as the Transforming Maternal Health. It's TMA, and I'm going to talk about that in a minute, to implement that grant, and that is a $17 million grant we received. We were one of 15 states. That'll carry over for 10 years. So we're very proud of our efforts there in implementing the lab and having a smooth transition. Our legislative initiatives for now include updating the newborn screening cap to allow for program growth and expansion, meaning adding more tests and being able to fund that. Increasing the state formula funding for local health departments. If you don't know, we get the money and we pass that down through a formula to local health departments. And they need those funds to carry out their duties, especially what's required of the federal and the state governments. And we want to establish regulations and licensing for the nuclear fusion systems. We are responsible for the nuclear radiation oversight, and a new fee structure needs to be put in place, and we are hoping for that as well. I will now jump into what's known as the Healthcare Finance Division, DHCF. An old term, it's the Medicaid program. So Medicaid is run, if you don't know, we are the single state agency for the state of Kansas at KDHE, but there's a big component that is administered by KDADS. We have a great partnership, but we operate the Kansas Medicaid program and the Children's Health Insurance programs in Kansas. It has to be in compliance with the federal rules. We have to get a lot of approval from CMS, and we want to promote healthy outcomes for Kansas enrolled and optimize on federal dollars that are available. Basically, we oversee all of the requirements of the federal government. KDAD oversees the disability, the HCBS, home and community-based services you hear about, behavioral health and long-term care populations. KDHE oversees all the other populations as well as responsible for managing the managed care organizations, which are the insurance companies that run the Medicaid program or that we contract with to run the Medicaid program. If you don't know, Medicaid and the CHIP, Children's Program, are a partnership between the state and federal government. The state designs its programs, and then we have to meet the federal requirements, but we add flexibility in to add additional populations or services to meet our Kansas-specific needs. So if we want to carve out a specific group of mental health or pregnant moms or whatever it might be. I've noted that CMS, the Center for Medicare and Medicaid, is who oversees the state program. There are a number of things in order for us to move forward, even if the state legislature approves something, whether it be funding, a policy, caseloads, whatever, we still have to get CMS approval for most of what we do. The feds pay 62% of our Kansas medical costs for Medicaid, 70% for the children's program, and between 50 and 90% for personnel, associated services, and all the IT costs that go with the program. Some key statistics for Medicaid as of October 31st, pretty consistently enrolled are about a total of 440,000 Kansas, 360 plus in the Medicaid formal, roughly 70,000 in the children's program, and about 16,000 in the maternal and child health integrated program. I don't have the estimated expenses on my slide deck, and I apologize for that. But we have all of that data, and that is reported at Bethel and all of what we go through. It's roughly about a $4 billion program in total. Eligibility for Medicaid, it's an entitlement program, meaning everyone who meets eligibility rules has a right to enroll in it, and we cannot cap their programs. There are different groups that have to meet different requirements to be eligible. Covered groups include children, caretakers, pregnant, disabled, or elderly. There are technical requirements to meet residency and citizenship, and financial requirements, and it depends on what category you are. Those percents of poverty level that you have to be at are different depending, again, on which category you fall in. The Medicaid division processes all the eligibility applications for Medicaid and CHIP, and the Department of Children and Families processes all the other public assistance programs, such as what's known as Temporary Assistance for Needy Families, TANF, and a Supplemental Nutrition Assistance Program, which is the food supplement program known as SNAP. There are many services covered by Medicaid. There are things that are mandatory, and then there are things that are optional. Mandatory examples must be covered if the state receives matching funds. Optional health care benefits the states choose to cover after receiving a federal approval. If federal approval is received, the state will receive federal matching funds for those services. Sometimes we receive 90%, sometimes we receive 70%, it depends. Children enrolled in Medicaid are eligible for medically necessary services and what's known as early and periodic screening, diagnostic, and treatment benefits. Some examples of mandatory services are what you'd get in a physician or a typical visit: inpatient, outpatient hospital services, physician services, lab, x-ray, transportation. Optional service depends, could be certain drugs, could be hospice, podiatry, durable medical equipment, wheelchairs, walkers, things like that. I would note that we have been what's known as a managed care state since 2013. 95% of the Medicaid population is in managed care, which means that basically you're in a system that agrees to visit only certain doctors and providers, and the cost of treatment is monitored and managed by an outside company, and we have 3 companies in Kansas that do that. Non-managed care programs include populations in the Medicaid, the PACE program, that's a program for all inclusive care for the elderly, and the tuberculosis program. They're paid on a fee-for-service basis, and that means they're paid each time you get a service. The 3 contracted Medicaid managed care organizations are Healthy Blue, which just replaced Aetna, Centene, which is Sunflower Health Plan, and then we have United Healthcare. So basically, patients are able to pick one of those managed care organizations to be their insurance company and manage their care. Major projects for Medicaid in the last year included this grant I talked about, which will focus on prenatal and maternal child health outcomes. This will include not only the state, it will include many organizations, including the midwife, the Hospital Association, the Perinatal Collaborative that's part of the state, and so forth. We will implement the KinCare 3.0, we're in version 3.0 of the managed care program, and this will include hundreds of changes from the last contract that we had. We will be focused on member outcomes, provider experience, and we will also be doing enhanced monitoring of the oversight of how those programs are being managed and those contracts are being carried out. Completed the unwinding. As you know, we were not allowed to do re-enrollment or check on eligibility during COVID. We completed an unwinding of all of the applications for members in the Medicaid program. We were recognized for our ability to get this done swiftly and accurately, and Christine accepted a national award at the recent National Association of Medicaid Directors meeting in November in Washington, D.C. for Kansas. We've been awarded the school-based services grant, and that will expand services available to Medicaid children in a school setting. And we've been working in collaboration, again, with United Health Ministries, David Jordan, and some other stakeholder groups, and that will be a good benefit for children. We have implemented a formal rate study for the Medicaid program. This is the first time this has been done, if ever, in many, many years, where we have some prioritization over which rates will get, and a formula by which those rates will get moved versus who will squeak the loudest and ask for rate adjustments. We are in the beginning stages, but we are making progress, and it's very systematic, and it will be more fair. And so I want to thank Christine for her work there. And there's been an outcry of wanting to see more analytical data related to the Medicaid program. So we have created a data and analytics bureau, and we plan to publish more public available information on our website. The goals for 25 for Medicaid include fully implementing the CanCare 3.0, initiate year 1 of the TMAW grant, the maternal health grant, complete phase 2 and 3 of that rate study that I just talked about, and you'll hear more about that in Bethel. And then complete research and recommend revised graduate medical education program for Kansas, and implement funding, or excuse me, public-facing dashboards on the managed care organization performance and other key Medicaid data that was not previously easy to find or available. That will help us inform our decisions, make sure our strategy stays aligned to what the contract says. So I will stand for questions and have my staff here with me to help me with any questions you may have. Thank you.
Committee questions of the Secretary. Representative Blex.
Thank you, Mr. Chair, and thank you, Madam Secretary, for the information. You made the statement of in 2024 we had 360,672 on Medicaid. Can you provide what the last 5-year trend numbers would be for the respective CHIP and the maternal and child?
We can get that in the follow-up.
If numbers are
yes,
increasing or decreasing. And then a second, if I may, Mr. Chair, if we do a policy change and requires a waiver from CMS, what's kind of the average timeline for that to happen? Does that take a year or 6 months, or what's the timeline?
I wouldn't say a year, but Christine, do you want to answer that question based on your history?
I'm Christine Osterlund, Deputy Secretary of Agency Integration and the State Medicaid Director. So the answer I'm going to say is it depends. So if you do what's referred to as a state plan amendment, so if you are approving a rate increase or new coverage, let's say we're going to cover a new healthcare service and we do that through a state plan amendment, typically those take about 90 days, but when they're approved in arrears. So if we submit it in January, even though it might get approved in March, it's going to be still effective for January 1. That's also true of like the home and community-based waivers. Those typically take 90 days to 6 months, depends how many rounds of question and answers from the federal government. If we do an 1115 waiver, which is what managed care used to be operated under in Kansas, there are no time limits. And so essentially the federal government can take as long as they like, and we have seen those go up to a year.
One more follow-up. I appreciate the rate increase. Now, is that going to be one of the common things that I hear constantly is reimbursement rates are terribly low. Is that rate study going to involve that, and what authority does the state have or influence? Well, I know the feds cover a lot of that and have mandatory issues.
Yes, so what the rate study is doing is it's going to compare Medicaid services to our neighboring states. So it's going to look at Missouri, Iowa, Nebraska, Colorado. So it will show a comparison of where our rate is. And if that state covers that same code, because again, sometimes we cover a code, they don't, vice versa, it will show where we are compared to our neighboring states. If there's also a Medicare code, if Medicare covers that service, you will also then see what the Medicaid or Medicare rate is. So we'll be able to do that comparison across states and also to Medicare.
Thank you for that. Thank you, Mr. Chair.
Any further questions? Representative Turner.
Thank you, Mr. Chair. Yeah, I was also interested in those numbers on Medicaid that Representative Blext asked about. I think at the height, before unwinding, we were up close to 500,000, if I'm...
Correct. Yes.
Yeah, so because I remember in a state of about 3 million people, we had about 1 in 5
Yes.
was on Medicaid in the state. Is that fair?
That is very fair. And yeah, and then during the unwinding, again, Medicaid enrollment fluctuates month to month, but really on average, we lost about 114,000 members during the unwinding. But you are correct that we were, I think, at 540,000 at our peak, and now we're back in the 400,000. Again, it fluctuates month to month.
And I also hear that over 50% of childbirths are Medicaid. Is that accurate, or do you know that?
Yes, yeah, it's right around 50%.
Of childbirths in Kansas are on Medicaid. And I had another question, actually unrelated, but you had talked about childcare, that you addressed 43 regulations. I don't know what addressed means. Did we streamline them, or did we add regulation, or what happened there?
Yes, we edited, streamlined, all of the above. It took a lot of work. We tried to make it better for the, not only the families, but the providers, et cetera. Ashley, do you have anything to add to that, other than that comment?
I'll just add, just for your knowledge, so we went about it a little bit differently when revising regs. Sorry, Ashley Goss, Deputy Secretary, KDHE. So we did go about it a little bit differently when we did it. We kind of did work backwards. So we involved the stakeholders at the get-go instead of involving them when they were getting ready to go to the AG's office. So we had listening tours. We did them 3 times a week, different times of days, a Saturday morning, so that we could get exactly what they wanted. Of course, we can't please everybody, but we feel very good about where we landed and where they're at.
So you did have, because I've heard some input from actual providers of they're struggling with regulation and actually just, for small businesses, which many of them are. So it sounds like that's something that you took into account and did the streamline. So
Absolutely.
All right, thank you.
Representative McDonald.
Thank you, Mr. Chair. I had a question about fully implementing CanCare 3.0 during 2025. Where are we with the community care coordination service, and when do we expect that to be fully implemented? Thank you.
It's a big question.
Yes. So we will be implementing the first pilots with that program in the spring of 2025, so just in a couple months. In fact, we just had a meeting on it this morning. We're expecting to be fully implemented fall of 2025.
Thank you very much.
Committee, further questions? Rivas. Can you turn your name badge around?
Sorry.
Committee, I apologize so much for that. I haven't learned all the new folks yet. Representative Rivas.
You're forgiven. It's just fine. I'm doing the same thing all over the building. So I have a question regarding the reimbursement rates and the comparison to the adjacent states with Medicaid fees. I know in Colorado, there was work done with the Department of the Insurance Commissioner to actually go with claims submitted with, like normal claim submissions with the medical rates, dental rates, whatever. So has there been a consideration to actually compare reimbursement rates to actual fees charged by the practitioners in our state versus just comparing to other states' reimbursements?
So the challenge that we have in Medicaid is the Centers for Medicare and Medicaid Services hold the states, if Medicare covers that code, we are not allowed, if we want to receive federal dollars, to go above the Medicare rate. Now, we can do state general funds only and increase reimbursement above the Medicare rate, but that's traditionally why we look to Medicare and the surrounding states and not to like what providers' expenses actually are or what commercial is doing, because many times those are so out of line with where our cap would be that it really isn't a good comparison, because as a Medicaid program, unless we want to do state general funds only, there really isn't a lot of options to reach those levels.
Okay, thank you.
Committee, further questions? Very good. Seeing none,
Thank you very much.
thank you very much for that. Okay, next we have the Department of Children and Families. Or Department of Aging and Disability. I call them the big three. And they've been on my mind just a tad bit here lately.
I won't take it personally that we're last, but out of the three, but that's okay, and being top of your mind. Thank you, Mr. Chairman. My name is Scott Bruner. I'm the Deputy Secretary at the Department for Aging and Disability Services. I work primarily with our state hospitals and our regulatory functions, but I'm here today representing Secretary Howard to present what our legislative agenda is for the 2025 session. You should have a document in your files that looks like this, just one page. We've got 4 bills that we're working on for this session. The first is around the Mental Health Intervention Team program. Last year, this is a program that funds school districts to employ school-based liaisons to work with students that have intense behavioral or mental health service needs and link them to other local service providers. The program has started in 2018, and since it was initiated, starting with 7 districts, we now serve nearly 100 districts across the state. Last year in the budget process, that moved the program from the Department of Education to KDADS to be the administrative agency running the program and distributing the funds. We've successfully transitioned the one staff person and the funding and the grants to our agency in the course of getting this started in this fiscal year. And the other thing that you did in the budget last year was also expand the ability for private schools to participate in the MHIT program as well. So for this year, what we'd suggest is, rather than have this administration move to us through a proviso in the budget bill, which took up a number of pages of the appropriations bill, to update the statute that would make KDADS the home agency for the program and make sure that the infrastructure that's in place to serve those school districts is stable and will last through the statutory provisions. That's a bill that we're planning to introduce through the House Appropriations Committee. So you may not see all 4 of these, but it is, you'll hear about the MHIT program at some point, I'm sure, during your deliberations over the course of this session. The second bill that we're going to propose is to name and create in statute a new state mental health hospital. Over the last 2 or 3 years, we've been working on a project with Sedgwick County to build a 104-bed state psychiatric hospital in south central Kansas. This will operate in a very similar way that our hospitals at Larned and at Osawatomie operate. We'll serve patients who are in acute mental crisis that are ordered by the court for care and treatment, or criminal defendants who need their competency to stand trial evaluated or restored. So this hospital, evenly split between the 104 beds, will serve both of those kinds of patients. Again, we've been working with Sedgwick County on the planning. We've got ARPA funding and other state general fund dollars in place to construct that hospital, but we need to create in statute the authorization for the hospital, give it a name, and also then give us the ability to actually set the administrative structure up so we can write a budget and do all the other things that happens with the state agency. So the name of the hospital that our kind of working name is the South Central Regional Mental Health Hospital. Where our location is in South Wichita at the corner of MacArthur and Meridian. And assuming we get all of our building permits approved, we'll be breaking ground or starting to move dirt the end of this month or early in February. So the timing is right. We can do everything we need to do administratively right now, but in anticipation of the building being available, we'd like to update the statute or create a statute so that it's has a home as well. The other thing we're going to do in that bill is update the name of Parsons State Hospital. Our state operates 2 hospitals for people with intellectual and developmental disabilities, one here in Topeka, the Kansas Neurological Institute, and the Parsons State Hospital and Training Center in Parsons. In statute, that's the way the hospital is named, Parsons State Hospital and Training Center. The training center part goes back to some historic functions that the hospital had as an extension of the University of Kansas, and it just doesn't really fit our model anymore. We don't really use operationally the training center names, and it's convenient while we're opening up state hospital statutes, we'll just update the name as well. So that'll be in that bill that should come through this committee in the very near future. The third bill is about the Civil Monetary Penalty Reinvestment Program. So right now in our, so the other part of my job is regulating nursing homes and adult care homes across the state. And we do that on behalf of the federal government that sets up a number of the rules that we follow. One of the mechanisms that's in the federal statute is the ability to charge fines or assess penalties if we find a facility that's out of compliance. And then the federal government lets us pool those monies together and use them to provide grants back to facilities or trade associations to provide training or maybe pay some expenses that are difficult for facilities to cover on their own. And sometimes the federal government directs us to use those programs to do particular activities. Around COVID, we were directed to give grants to facilities to provide barriers for visitation and other kinds of things. So we have those in our federal programs. They don't exist on the state side. So where we regulate facilities, assisted livings, adult care homes, and providers of disability services, we regulate them. We have the ability to assess fines if we find things are out of compliance, but all those fines and penalties go immediately back to the state general fund. So what we'd be suggesting in this bill is to create a program that would allow us to capture those fines and penalties in separate funds and use them to benefit the providers that would pay them. The statute sections are there in the description. Again, the idea would be the same. We'd pool those funds together and then use them for quality initiatives in those program areas, or be able to provide grants for if a facility needs a new HVAC system or a significant large water heater or boiler. Those capital costs are really hard for some smaller facilities that operate on very tight margins. So that would be our plan, to create these separate funds, use fines and penalties to kind of populate or put money into the funds, and then develop grant programs that we could use to really support and enhance the service provision around the state. And then the last bill is around outpatient forensic competency. You're getting a lot of terms thrown at you, where I'm doing that, and I apologize, but please ask questions. So the last topic is around forensic competency. So one of our functions at KDADS is to evaluate whether a criminal defendant's competent to stand trial, and if they're not, restore them to competency so their criminal process can continue. We've been in a lawsuit with the American Civil Liberties Union about wait times for those competency evaluations and restoration. We recently entered a settlement agreement that gets us out of the litigation, but puts some requirements on the state to do a lot of reporting, for one. But another item is that we agreed to propose legislation that would address some of the timing and where those evaluations and restoration activities can happen. So what we'd be proposing in this bill, again, based on the settlement, is legislation that would make outpatient competency restoration and evaluation the primary source before anybody would be ordered to come to Larned State Hospital or another state hospital for competency evaluation or restoration. We right now work with a number of counties, jails, law enforcement, mental health centers to do competency services in jail settings or in the community. This would just change the statute so that, as opposed to a judge being able to order a defendant to Larned State Hospital or another location, the first place that they would be able to order is to community treatment. If the defendant's not successful into the community, or there isn't a community option available, then you'd be ordered to Larned State Hospital or another of the state hospitals. Again, this brings us into compliance with the settlement agreement to propose the bill. So that's what we would suggest. The other item, or the other part of the bill, would make sure that KDADS receives every order by any judge for a defendant to receive competency services. Now, it's not required unless the person's coming to Lawrence State Hospital or Osawatomie State Hospital. One of the requirements of the settlement is for us to report on every single defendant around the state and what their status is and how long they've been waiting. That would be a lot easier to do if we had all of the orders for everybody who's in the process. So we'd make that change in the statute as well. So 4 bills, 2 of them will come through your committee, Mr. Chairman, the regional hospital naming and the civil monetary penalty bill. The other 2 we're going to introduce through other committees, but again, you may see them at some point or hear about them in the course of your work this session. With that, I'm happy to answer questions.
Very good. Thank you, Mr. Deputy Secretary. Representative Blex.
Thank you, Mr. Chair. Thank you, Mr. Deputy Secretary. Question on your fine situation. How much flexibility do your field people have now as to whether an amount or whether to or not, I assume, currently within your current system?
So the state regulations that this falls under, the penalty amounts are set in those regulations and statutes, but the trigger to assess the fine is repeated noncompliance. So this doesn't happen on the first pass, and it's only for the most serious offenses or violations that we find in regulation. So we wouldn't be changing any of those, any of the conditions. We'd just be redirecting where the money's going.
Well, this kind of concerns me, like a small town cop that's sitting outside writing speeding tickets to benefit the city treasury. We see a lot of that, and we're certainly have that, even though it may not happen, it may have that appearance to, if I rob a bank and get caught and put money back and then apply for a grant to rehabilitate myself, I guess I'm not sure how that's going to work. Would the facility that is guilty or being fined, would they be also eligible, I'm assuming, for one of these grants? If there is a time limit, or do you know at this point?
We're still, well, we'd like to get the authority and then work on the regulatory part. There may be some times when that would happen. The grant programs that we're considering following the federal model are not directly related to the things that we cite people over for and penalize and fine them for. So if it's a lack of successful treatment or somebody's injured in their facility, that's when we would trigger a fine. We're not going to give grants to facilities to hire more staff or to supplement that. It's going to be for infrastructure, capital improvements, maybe training, so that there would be a chance if what we saw in the process or why the fine was generated was because somebody wasn't adequately trained in how to do a transfer or provide care to a patient. Training not just that person but the whole facility, making sure the training curriculum is maybe more advanced or simpler to follow. I mean, that would provide quality to everybody who's being served, not just the one person who was injured. So the idea would be to have provide grants for things that are broader than just one individual or one facility.
Thank you for that. Thank you, Mr. Chair.
Representative McDonald.
Thank you, Mr. Chair. I might have misunderstood, but when you impose these fines, would that money not be spent on ways to improve care rather than, like, I assume these are for-profit businesses, so like I would hope they wouldn't get a new hot water heater based on being fined, right? Like that's almost rewarding bad behavior for a for-profit company. So I guess my real question is that sort of example something that would happen? And in what ways can we use these funds, or do we use these funds to improve patient care? Thank you.
It's a great question. On the federal side, a lot of the initiatives that CMS, the Centers for Medicare and Medicare Services, authorizes are quality-based, so about patient-centered care, trauma-informed care, those kinds of things that really do relate to quality of care. What we have seen through COVID in particular, but even before that, were some programs where they authorized us to use our CMP funds for infrastructure where the facility can't, maybe they're being cited or they're under some compliance because they can't keep their water temperature high enough, which affects everybody in the building and is directly related to quality of care. So in that case, it would make sense if they can't afford or with some qualification of the application, and show that they don't have the ability to pay for that water heater upgrade to use the grant money for that. So I think there would certainly be some standards applied. We wouldn't look to reward additional bad behavior, or if there wasn't, a good reason, financial justification to award a grant, we'd be looking for those qualifications as well.
So it's discretionary on your part largely, or?
I wouldn't use the word discretionary.
Okay.
We'll put criteria together, and
Okay.
then everybody will have the ability to look at that and apply as appropriate. It's not a checkbook for me to write grants to people, but we'll try to create programs that address issues that we do see on inspection and survey, which things like water temperature, older HVAC systems, maybe where there isn't good air quality and people want to put in filtering systems. Those are things we see on survey. So we'd try to address those overall problems by making money available for facilities that need that help.
Thank you.
Representative Gardner.
Thank you, Mr. Chair. I would like to get some clarification, if you would please, about a situation like if a person is being treated at a state facility for mental health impairment, and then they are rehabilitated and released with medication, and they are in a local county, and they get arrested and charged with a crime, and the judge then requires a assessment for competency. Is the full responsibility for payment of the cost of holding that person bore by the county, or is there any way that the state has any financial responsibility in that? Number two, is there any limit as far as how long that individual can be held before they can get into an assessment, get an assessment done, for instance, at Larned? And three would be, is there any way that the state can be involved in allowing medication to be given to that person being held? Because, it appears that the city, or the county law enforcement does not appear to me to have the authority to administer medication. Could you address that problem for me, please, and give me some clarity about how that can proceed forward and what the state's role in that is?
Yes, I'll try. If I miss something, please redirect me. So I think your first question was if somebody's arrested and needs their competency evaluated. I'm going to separate that from whether they just came out of a state hospital or not. It really doesn't matter for our purposes. But if a judge decides that a defendant that is in their court, there's some question of whether they're competent to stand trial or understand what's going on, then the judge can order them to have their competency evaluated. That until the judge has the discretion of ordering where that evaluation happens. They can order them to go to Larned State Hospital, the State Security Hospital at Larned. They can order it to a private psychiatrist or healthcare mental health professional that works with the judge to do that evaluation. Or in our current structure, you can order that to go to the community mental health center, and they can conduct the evaluation inside the jail or through their facilities. Until from the time when that order is issued by the judge until the evaluation actually happens, the county is responsible for housing that defendant inside their jail. They're a criminal defendant under the authority of county law enforcement, and so that's where they're being housed in the jail. So that's what happens today. We did start a program 2 sessions ago 2 sessions ago, under Senate Bill 228, that authorizes KDADs to pay up to $100 a day to a county jail while a defendant is being held waiting for placement at Larned. So, and the counties can submit reimbursement requests to us that start on the day of the order for evaluation and ending on the day when the person's admitted to Larned. And then we pay $100 for every one of those days, the quarterly process. We can go more into how that works. But so we've been doing that for the last 2 years. And we can bring the information, we presented it at Bethel, but we can bring that to this committee of what we've paid out and what counties have participated. $100 a day isn't covering the whole cost, but it's significantly more than they were getting before, but, and that's the rate that we agreed on with law enforcement and county officials. But, so we do offset some of those costs. Not every county participates in that program. We've tried to make it, I won't justify the program. It exists. The other parts of your question, is there a limit on how many days somebody can wait? No, there's not. And sometimes those wait time, the average wait time at the moment is a little over 350 days. Some are shorter, some are longer, but that's the average for people that we've admitted over the last month. Sometimes that happens because the evaluation's ordered and the defendant won't cooperate, and so we have to figure out how to get the evaluation complete with an uncooperative defendant. That takes more time. Sometimes there are multiple rounds of requests, or the prosecutors and defense counsel may have some argument over what needs to happen, and that delays the timing. But in terms of our work or the competency work from when that defendant is ordered until they're admitted or their competency evaluation is completed, we're counting all of those days. But sometimes there are things that happen in between. But there is no limit in statute for that. And then your last question was about medication to people in jail. So we've had a lot of conversations with jails and counties that we've been partnering with to figure out how to do the competency restoration in the jail setting. And we've got several pilot programs in counties where courts, law enforcement, jails, and mental health centers are working together to figure out how to get care and that restoration service inside the jail setting. One of the obstacles is medication often, because that sometimes is what the defendant needs to get stabilized enough to be able to participate in their defense and have their competency restored. So some jails have more capability to provide that medication service and management, depending on it often is related to size, that they may have an outside vendor that does health care, they may have a physician or nurse or service that they work with, and so they can do that. Many jails don't have that much health care inside the jail setting, so it's harder to do. We have been asked from time to time, is there a way we could be the prescriber from the state hospital to the defendant in the jail? That gets my lawyers really excited. It often gets county lawyers really excited, and then just they're not on our campus, they're not an outpatient. We don't really have an outpatient service. We haven't figured out how to do that yet, quite honestly. But we have talked to a lot of counties about if we could figure out how to do the medication piece, what other things would work along the way. And working with mental health centers has worked in some communities. Working with the medical providers that work with jails has been successful in a couple of communities. Shawnee County, we've got a good start on a pilot project here that would work from there. But that is one of the obstacles that we are trying to figure out of how to get, because some of the medications that work either are injectable, and so you need to have a medical provider that's doing that. There are some side effects that you want to be aware of, and then the highest tier is that some people don't want to take them. So one thing we can do at the state hospital is provide that medication over objection in some limited circumstances. And we have had some discussions with law enforcement and counties and jails about what would that look like to give the sheriff or whoever operates the jail the authority to provide or to dispense medication over a defendant's objection. That also gets lawyers really excited. Can get them excited, but that's one of the obstacles that we are trying to figure out and work through. And yeah, that's one thing we are trying to figure out and work through. So we are compensating jails for a little bit of their cost while they're waiting. There isn't any limit on how long you can wait, and medicating people in jail would be one thing that would probably help shake some of that wait time, make it shorter. But there's some operational, legal, medical hurdles that we need to keep working on. I think I got all the parts of your question, but I'm happy to try
Thank you
again.
very much.
Very good. And committee, just in the future, if we would just ask one question at a time. Scott, thank you so much for remembering all three of those. I would have had to say.
I wrote it down,
Oh,
Mr.
you did?
Chairman. Yeah,
Okay.
no,
I would
wasn't
have
gonna
said,
trust.
what was your second question? So committee, if we will, I'll certainly let you ask 2 or 3 questions again, but if we would just let them answer one at a time so that it'll just make them easier on them. So Representative Bryce.
Thank you, Mr. Chair. Thank you, Mr. Bruner. I just had a quick question. I'm curious about the penalty assessment, the fines. Is there a general, can you give a general number on what size these are? I'm just curious about the size, how they might relate to incentivizing facilities. Thank you.
I'll bring that back or share it with the committee. There are limits, and I don't want to trust my memory after I just did the mental exercise of 3 parts of one question. I'm a little shaky. I think on average that we're talking about $3,000 or $4,000 in most cases, but I think our maximum is higher than that. But I'll bring that back for the committee so you can see it, and that's important as we propose the legislation as well, so you get a sense of what we're talking about per incident.
Committee, further questions? So how much money, so I just have a couple, Scott, and some, maybe some soapbox here. We have done a really good job in the last few years of improving our competency and evaluation. Scott has been really involved in getting some more folks on that can evaluate these folks, especially in Western Kansas, working with Wheat State, which is a community mental health centers and stuff like that. And so, and then coming along with the money for the sheriffs, because some of these folks, they're sitting in that jail for 100 days and it's costing them. So we have, and this legislature has ponied up quite a bit of money in the last few years to try to get those kind of situations taken care of. So I'll just say that. How much are we talking about, Scott, annually? For fines, I mean, on average,
it's in the ballpark of $250,000 to $400,000 across all of these licensure types. It'd be over a couple of different funds, but $250,000 to $450,000, something in that ballpark.
Okay, very good. And I might add, committee, we will have that bill before us so we can put some guidelines on how that money will be spent. So, okay, committee, further questions? Man, they let you off easy.
I think so. Thank you.
Okay, committee, anything else? Well, thank you. Representative Howell.
Thank you, Chair. I just wanted to point out that last meeting, you did say this was going to be a fun committee. Is that correct?
I might have exaggerated a little bit, but.
Well, I'm just wondering about this chair and desk in the corner. That kind of looks like a timeout chair. So I'm feeling a little nervous as a first-time person, first time on this committee. So I'm just wondering about that. That's all.
I'm going to go ahead and let you wonder about that. All right. Thank you very much. Thanks, everybody. We're adjourned.